Good evening, everyone. This is Ben Braffman, the founder of the Academy for Addiction Professionals. Just a quick note, we're actually going to change the name of the Academy. The Academy is going to stay the same, but we are expanding our bandwidth, and we're becoming a much more robust educational provider. And so we're going to be called the Academy for Behavioral Health Professions, like many of you are. So if you need any information further than that, we're going to, you can catch us on addictionacademy.com and benbraffman.com. Okay, so here we go. Let's talk about diabetes and mental illness. The prevalence of physical psychiatric illnesses are closely interwoven. 60% of patients needing mental health care are being treated by medical practitioners. 50 to 80% of patients treated in medical clinics have a diagnosable psychiatric illness. 50% of patients in psychiatric clinic populations have undiagnosed medical conditions. Diabetes and depression and anxiety, they really do overlap. Bottom here is 10% of self-referred psychiatric patients have symptoms that are due solely to a medical illness. I think that percentage is probably a little bit higher. I think that the conditions are really connected to each other. We're going to get into that a little bit more. And I do want to self-disclose, I am a type 2 diabetic. I listed the symptoms of diabetes for myself, and there was well over 200 symptoms that people can suffer from. So a debilitating disease, as is depression and anxiety. The prevalence of diabetes is a serious global health issue currently affecting 425 million people worldwide. By 2045, it is expected to affect 690 million people worldwide. Those are unbelievable numbers that are staggering. And we are heading, our society is heading more and more into the belly of this disease. This disease is not going away. I will say that there's a lot of medication for type 2 diabetes, but it's one of those diseases does not get a lot of attention like cancer or heart disease gets, and it should. It is an absolute killer. And, the bottom line is people could say, well, go ahead and change your lifestyle, which we're going to get into here a little bit. You could change your lifestyle, but the fact is that should you really be punished with a disease because you like hamburgers too much? I struggle with that one. Obviously, taking medication and exercising and limiting your stress are all very helpful. Now, there's stress for us. Stress increases your blood glucose, and it stimulates the wrong hormones in your body. Yes, you could literally eat right, sleep right, exercise right, but you are so stressed out, let's say at work, that your blood sugar is out of control. And so I wanted to just talk for a minute about blood sugar. If you could imagine that your blood is being hijacked by a pirate ship, and your tendons and your nerves are being destroyed by a pirate ship, that is what diabetes is doing to your inside. Imagine there's some ghostly pirate ship that's traveling the 7 seas of your of your blood all over, and it's looking for a port. It's looking for a way out. Remember that we're dealing with sugar, which is supposed to turn into energy, and you're supposed to use that energy and get rid of it. And in diabetes, the mechanism of that doesn't work. So we have to be diligent about it. We have to make sure that we're getting rid of the sugar and the pirates that are in our bloodstream, and making sure that they don't dock on our tendons and our nerves, which is why a lot of times our feet are so affected by diabetes, because it's so far away from the heart. The heart has to work extra hard. So there's an interface here, and I mentioned this before, between medical and psychiatric illnesses. They're intertwined. You have the psychiatric illness, so you have to address that. You take medication for it. The medication may or may not affect your diabetes. You have your diabetes, and your metformin or other medications, your injections may affect your mental illness. So you have got to balance yourself. Treatment challenges. Psychiatric disorders in patients with diabetes has a low detection rate. You know why? Because everybody's worried about the anxiety and depression and schizophrenia and bipolar disorder, and probably worried about the fact that you may end up killing yourself. And so diabetes does not even become part of the discussion. I will tell you this, that many alcoholics that end up in treatment, I would say about 80% of alcoholics that are in treatment are either diabetic or insulin resistant, and it's never picked up on. And it's actually one of the factors in which they relapse, because if you don't deal with your diabetes, some of the side effects are you're moody, you don't feel well, you don't sleep well, you don't eat right, you don't socialize correctly, and it becomes a problem. So drinking becomes an option. Approximately 50% of those with psychiatric disorder is not recognized nor treated in patients with diabetes. Psychological issues, diabetic regimen, dietary considerations. Point blank, we were never taught how to eat. Oh, there's Weight Watchers and there's school programs and there's all kinds of exercise gurus out there. But think about it for a minute. As adults, when were we taught actually how to eat? For example, did you know that you should eat a protein first, then your vegetable, then your carbohydrate? I didn't know that until I was well into being an adult and actually got diagnosed with diabetes. I figured it all goes into the same place. So what's the difference? The difference is that as a diabetic, your body digests things differently. And so we have to learn how to eat and make better decisions. Low fat, low carb, high protein diets seem to work. And obviously exercise is a major factor in all of this. We have to monitor our blood sugar. Some of us get obsessed with it, turns into an anxiety disorder. We have to remember about our insulin injections, or we can suffer consequences to that. Fear of hyperglycemia versus hypoglycemia. Between the two, I'd rather my blood sugar be low, so I can build it back up than being high and off the charts. That's just a terrible feeling to have. The fear of injection, if people have that, and a decreased in quality of life. If you are a diabetic, you will have a decreased quality of life if you don't take care of yourself. It's one of those things where if you don't do something about it, it's going to do something about it against you. Common comorbid diabetes and psychiatric disorders. So with type 1, we've got major depressive disorder and obsessive compulsive disorder. They go hand in hand. A lot of low energy, a lot of seasonal affect disorder, a lot of different depression, suicide ideations, obsessive compulsive with taking care of yourself and constantly thinking about the structure of your life and how it relates to your diabetes. And type 2 is major depressive disorder, and in this case, somatization disorder, which of course, every ache and pain that you have, you think that it's related to your diabetes. It's probably not, but because you don't take care of yourself and the diabetes your blood sugar remains high, other things can happen. You get high cholesterol, high blood pressure, you're overweight, you're obese. These are all problems that can occur because of high sugar. Chronic illness and depression, heart attack, 40 to 65%, cancer, 25%, diabetes, 15 to 20%, COPD, 40%, and chronic pain, 30 to 54%. So chronic illness and depression combined with these, it's really, really deadly. The stats are just staggering to me. It's almost depressing, to discuss it. And we really need to take care of ourselves. There's a prevalence for depression, mental and behavioral disorders, a leading cause of disabilities globally. Think about that for a minute. You guys are in the right field. Leading cause of disability in the US, ages 18 to 25. So somebody who's depressed, somebody who has a behavioral disorder is in that category that needs the empathy and compassion that we need to give as professionals. Affects approximately 16 million American adults, and it's prevalent more in women than in men. Depression is everything that it's cracked up to be. In fact, I don't think it should be called depression. Depression sounds like a road sign. I think it should be called the abyss of hell. Prevalence of diabetes and depression doubles the risk of having depression. Exposes yourself. You feel sad, you don't feel right, you don't sleep, you don't eat, you get depressed. The rate of depression for the general population, 3 to 5%, increases significantly to 15 to 20% with diabetes. If you're not constantly on yourself and structured, the diabetes is sitting there doing push-ups, and it's waiting for you to take a day off. It's waiting for you to have a bad month. Depression is under-recognized and undertreated with patients with diabetes. When they coexist, they may even worsen. Symptoms of depression: anhedonia, not feeling, hopelessness and helplessness, indecisiveness, weight gain or weight loss, fatigue, sadness, suicidal ideation. The weight gain and weight loss is also a big factor. Women who are diabetic and they're gaining weight, it is a deadly combination. And men too, when they're trying to exercise and they're trying to change their get their six pack and their dad body, and the diabetes is impacting them. Symptoms of depression with patients with diabetes: impaired quality of life, increased cost of care, poor treatment adherence, poor glycemic control, increased ED visits due to diabetic ketosis. That's a big one. Your important stuff as men stops working, and you should start to pay attention to it. Again, there is medication for ED, but at what point are you taking just a closet full of pharmaceuticals? And of course, disruption in life, your family, social, and work. Depressed patients less likely to adhere to treatment and probably going to have diabetes complications. Listen, when you're depressed and you don't have meaningful life, you're not going to do as many things for yourself, and you've got to. There are support groups that are very important. I can get you the information on support groups. You got to talk about diabetes. I guarantee you that more people have diabetes than you think have diabetes. Depression, a goal of treatment is the complete remission of symptoms in all areas. Anxiety disorders: patients with diabetes are 20% more likely to have an anxiety disorder. Patients with diabetes have increased rates of obsessive compulsive disorder, post-traumatic stress disorder, and agoraphobia. Difficulty differentiating symptoms of diabetes from anxiety disorder. So they really mask each other, and you really need to do a thorough intake and a thorough history on a patient. One of the best questions to ask is the family history. And the other thing is find out what medication the person has taken in the past and what medication that family members have been on. And you start to get a profile of what's going on with the patient. Symptoms of anxiety in patients with diabetes: fear, sweating, tremors, tachycardia, confusion. I've read cases where your heart could actually swell because of diabetes and the high cholesterol that you're having. Other comorbidities are eating disorders, alcohol use, schizophrenia, bipolar affective disorder, delirium, smoking, sleep disorders. It's all very common sense, but it's really going to happen. Alcohol use and diabetes is directly affected with each other. Eating disorders and diabetic is directly impacted with each other. And in fact, you may have gotten diabetes because you have an eating disorder. Treatment. There's different types of treatment. There's the state trait anxiety scale, education regarding your illness and severity, antidepressants that you can take, and of course, talk therapy, which is very popular. But I'm a big group guy. I think that you can find like Emotions Anonymous and group therapy and speak to a psychiatrist to get balance in your life. Ramifications of failure to achieve remission. Well, pretty obvious, but you're going to keep relapsing, possibly on drugs and alcohol, possibly on sugar, and certainly on the lack of taking your medication. The higher utilization of medical services. The less you take care of yourself, the worse you're going to be. So your medical expenses go up. Lower quality of life and workplace issues. Treatment-resistant depression. 60 to 7% of favorable responses, 5 to 10% have failed to respond. That's an interesting statistic, if I may. If you get your diabetes under control, the literature suggests that your depression will follow. It's very interesting when you think of it that way. If you take care of yourself first, right, and you start from the outside in, your depression will lessen. Failure to respond leads to questions of appropriate diagnosis and treatment. Some people are misdiagnosed. They're not depressed at all. They just have diabetes. And I don't mean just, but they have diabetes, which can mask depression. Treatment-resistant, potential reasons for treatment-resistant, undertreated depression, incorrect diagnosis of psychiatric disorders, undiagnosed co-occurring psychiatric disorders, undetected substance abuse disorders, undiagnosed sleep disorders, and undiagnosed co-occurring medical conditions. It is so important to do a major history on somebody and really get to know what somebody has been up to and what their family history is. This is underreported because the behavioral health and frankly the healthcare industry is stressed. They don't have the bandwidth sometimes to get into the underlying diagnoses, but they really need to. Summary: diagnosis of a chronic medical condition serves as sufficient for an in-depth screening for psychiatric comorbidity. So if you pick up on somebody having diabetes, get right into whether they have depression or anxiety. Diagnosis of psychiatric disorder serves as sufficient for an in-depth screening for associated physical conditions. Just rule it out. What is the history? Goal is for symptom remission, improved quality of life, and improved management of chronic physical illness and level of functioning. So the takeaway here is comorbidity of diabetes in a psychiatric disorder is common and can have different presentations. Diabetes is unique to everybody. What presents as diabetic to one person may not be for the other person. Again, they may be similar, and diabetes is similar because it is a disease and you share certain things, but your personality changes, how you approach things, how you deal with problem solving, your frustration level. And lastly, laughter is the best medicine. Well, unless you are a diabetic, then insulin is probably better. It's just a dark joke. So I hope you enjoyed this presentation of depression and diabetes, mental illness.